Hello, and welcome to this webinar on staffing workflow optimization. I am Cassidy Avila from the Center for Optimizing Rural Health at Texas A&M University, and I just want to thank you for joining us today. In just a moment, I will introduce our speaker, Ms. Lindsay Corcoran, but first I do want to let you know that we are recording the webinar, and we will be sharing a copy of the recording with you along with a copy of the slides in an email either later this afternoon or tomorrow. And we will leave time for questions following the presentation, but do feel free to go ahead and put your questions in the chat if you have any. And after the presentation, we will make sure that Lindsay sees them during the Q&A portion. And so with those couple of announcements, I would love to go ahead and introduce Mrs. Lindsay Corcoran with Stroudwater Associates. Lindsay is an accomplished consultant and practice management professional with over 10 years of healthcare and medical office experience. At Stroudwater, Lindsay focuses on supporting and sustaining healthcare access for rural communities through hospital operational improvement and affiliation strategies, and has assisted rural and community hospitals and clinics across the country to improve operational and financial performance. Results-oriented and highly organized, Lindsay is a skilled and effective communicator with medical providers, patients, and administration. Before joining Stroudwater, Lindsay worked in an outpatient facility therapy setting as a practice administrator for 3 clinics in Southern Maine. She is a graduate of the University of Southern Maine and earned her master's in healthcare administration in August 2013 from Seton Hall University. She is also a member of the American College of Healthcare Executives. Thank you so much for being with us today, Lindsay, and for sharing the excellent information that you have. And I will hand it over to you now.
Great. Thanks, Cassidy, and welcome everyone. Thanks for joining today's webinar. I'm sure this is the topic that is certainly on everyone's minds, and it's probably been for the last several years or maybe even longer. But really what we want to focus on today around kind of looking at your staffing workflows, because, we can't get more FTEs, they're not out there. It's harder and harder to recruit additional folks to our healthcare facilities. And so what are we going to do with the folks that we do have? And how can we further support them? And one way that we are looking at it is through process improvement methodologies. So is there a way that we can really focus in on the value add activities that will make for a happier and more engaged workforce, and really eliminating some of that waste that we see all throughout healthcare and frankly in any industry. So you may be familiar with some of this terminology and some of these methodologies, but really it's an opportunity to look at and taking some of these methodologies and really focusing it on our workforce in our workflow specifically. So I am going. So really what we're going to cover today is really around kind of how do we get here? What's the current situation in healthcare from a staffing perspective, and how do we get here? We're going to talk about what is value add and versus non-value added activities, and what are some solutions? And we break that down into 4 different parts that we'll go over. And how can we take some of those solutions and apply it to our looking at our workflows specifically to support workforce. And we'll have some opportunities for questions and answers at the end. This is me. Cassidy made a nice introduction there, but really, if you're not familiar with Stroudwater Associates, we are a national healthcare consulting firm. We really focus on rural and community hospitals, doing a lot of strategic, operational, and financial improvement, as well as clinical and quality. So, you may have encountered us in some of your organizations, but really here to support and really focus on our rural communities as well. So really, these are kind of ripped from the headlines, and you probably have read this. You're probably experiencing this, where there's 1 in 5 healthcare workers have quit their jobs, just left. We have, folks leaving in droves, just getting out of healthcare. We know that by 2026, there will be over 500,000 nurse shortage. That is a significant number. But the shortages are nothing new, but it's just been compounded by obviously the pandemic. And 30% of nurses are just leaving direct patient care anyways. So we're really in this staffing crisis. And in healthcare, it's always really kind of experienced that, but now it's really just kind of been significantly impacted due to the pandemic. And you're seeing it in other industries as well. And really, talking to folks today, it's really around burnout. There are the folks that are in your organizations that have, been there through and through, stood by your organizations through the last several years, and they are just gotten to a point where burnout is significant. And certainly, a increased kind of, focus on mental health, and folks are just tired, and it's not good. And I know I'm preaching to the choir for anyone who is in, operations. It's not great. And so we're really having to kind of think about how we support our staff differently. And whether that's, and how do we get additional staff? What is their recruitment and retention strategy as well? This is all, not new, but we have to think about it a little bit differently, given kind of the circumstances that we are dealt with. But again, ripped from the headlines, we are certainly, a emergency order had been issued really around hospital staffing. It's that, and specifically if you're in a rural community, which I'm sure that the majority of you are, rural has been impacted much higher than the urban areas. And so not only do we have already a disadvantage of recruitment and retention because we are in a rural community, but our workforce is just shrinking in general. Folks are departing and leaving the rural communities. So again, we are rural hospitals and healthcare organizations are already at a significant disadvantage. So, and again, you can probably check off every single one of these boxes. And these are some of the things that we've heard from healthcare organizations and what they're facing now. You have the competition and the high cost related to staffing agencies. Sometimes we just have to bite the bullet, and because we need to fill in positions that are vital to our organization to sustain services, we needed to go out and get agency staffing. We needed to maintain patient safety, and we needed agency staffing, but that comes at a high cost. And the staffing shortages has led to fatigue of our healthcare workforce. We have an aging workforce. We have folks that are wearing multiple hats. This is nothing new to rural communities and hospitals and healthcare organizations, but it's when we lose staff and there's nobody else to fill that position, the tasks still remain. The activities in which that we need to do to kind of continue to support operations, they still remain. So all of that goes on to somebody else, in addition to the other kind of activities that they're responsible for doing. So we still have, the juggling of multiple roles and responsibilities. Raising salary costs, a lot of organizations gave out bonuses, increased wages, really to continue to kind of recruit and retain staff, not only nurses. I know that there were and still remains, working with a hospital in Louisiana, they were offering a $20,000 sign-on bonus for a lab tech. If that is where we are having to kind of compete with urban hospitals that are kind of really focusing on that, that dollar to recruit folks to their organizations. And it's much harder for our urban healthcare organizations to be able to do that and sustain kind of financial viability at the same time. And then, certainly the cost of supplies. We're also seeing not only the cost of the supplies due to COVID, now we're seeing it because of inflation, and that it just compounding and increasing as well. So how do we get here? This is not something that's new that we just started talking about since COVID, but we have gotten to a place where it's really, really difficult to even kind of see the light at the end of the tunnel. But from a nursing shortage perspective, so just when we think about kind of the nursing role, we've had, this aging workforce. So we're having, retirements are happening. And at the same time, we have a declining number of faculty for nursing schools. So we have an aging faculty at the same time. So we're not building the pipeline as fast as our nursing folks are retiring or aging out of the workforce. And so, it's the supply and demand. Then we also have a decreasing number of clinical sites and resources. This is sort of starting to change because the federal government is also really encouraging folks and also, giving out grants and funding related to universities and hospitals systems partnering and really kind of starting to kind of advance and build that pipeline with opening up more sites and more resources, given the fact that there's been a decreasing number of sites over the several years. We know that also, even just in the technical schools, your lab techs, your rad techs, those numbers, the schools are closing at a pretty, or programs at these schools are closing. Then you also have, hospital expense reduction. We know that nursing is one of the largest expense items that we have. And that is always like one of the areas that we want to look to reduce costs is in our nursing. So, a lot of times we are seeing that expense item is being reduced, but at the same time, what else is that impacting? Then we have throw in the pandemic, we have the burnout and the kind of the increased need to support an aging population. So we're having sicker people, we're having more older folks who tend to use more hospital services than our younger, healthier population. And so we're going to be having more patients access the healthcare system. And how are we going to be able to support that when all of these multiple factors are happening at the same time? So lots of things going on. This isn't something that's new. It's only continuing. And it's really just to kind of set the stage on why we have to maybe think about the staffing component and looking at our workforce in the mindset of workflows. So what are some of the risks of not kind of addressing workforce and workflow? And so when we don't, focus on how can we better support current staff and work to kind of continue to recruit, we shut down services. How many folks have shut down, had to shut down a clinical service line because of lack of staffing, or reduced the services, or had to reduce the beds. I've been in multiple hospitals recently where, it's a 100-bed hospital, but they're operating at 50% capacity because they can't staff, 10 additional beds. So, thinking about that is certainly a risk. You have quality and safety concerns. When we don't have staff, or we don't have an engaged staff, or, you have a burned out staff, things may happen. And we would never want to have, any adverse events or quality or safety events, poor outcomes to happen because of lack of staff or unengaged staff. Staff morale and culture is definitely imbalanced. Seeing this a lot. And again, this is probably the hardest thing to ever change is culture in an organization. But if we can start to kind of think about how we engage our staff and get them kind of on board, hopefully it improves some of that morale. Certainly a financial strain to the organization if, the high cost of staffing agencies, it can certainly make an impact to the organization. And then at the, really dissatisfied patients, they will know when there's something wrong in the organization. And it comes through with our patient care and leading to maybe dissatisfied or not satisfied patients. So what are some kind of value add versus non-value add activities? And how do we kind of think about that when we're looking at our workflows? And you can see here in healthcare, waste is anything that is any expenditure of time or resources that does not contribute to the efficient delivery of patient care, or it doesn't add value to the patient care experience. So we want to think about this as kind of patient-centered as well. In non-value add activities are all other actions or unwanted features by definition. So anything that is a waste. And so this is just a nice little snapshot of what we think, asking an organization what we do on a day-to-day basis that is considered waste. And we're going to talk about each kind of the waste categories. There's 8 of them. And so what activities are happening that contribute to some of that waste or that non-value added activities. So if you think about it during your course of your day, how many times are you doing something that is just, why are we doing this? And you ask that question, like, is this necessary? And sometimes it is, and sometimes it's we just have to do it. But are there some things that are really just not necessary, doesn't add any value to oneself or to the patient experience? And those might be that fall into that waste wheel there. So waste impacts, and I said we were talking about kind of patient-centered. It impacts the patient, the staff, and the organization. So how many times, have you experienced, and so these are all the different ways in which, waste could impact the patient. So long wait times, can lead to increased stress. There can be less time for care and education. So, that, and then redundancy in treatment is considered a waste, and really leading to kind of bad overall patient experience. Waste can impact certainly staff members, where there may be maybe it's an unpredictable work schedule, or there's lots of redundancies in paperwork that really can lead to some of that staff dissatisfaction, low morale. There's no time for education or psychosocial care. So that's going back to that mental health and that burnout. That waste can impact, high staff turnover if there's a lot of waste in the organization, and there's no kind of, there's lots of redundancies and there's no value added activities, can really contribute to some of that staff turnover. And then, constantly running around. How many times maybe you're an executive at your organization and all you do is put out fires? Maybe that's the opportunity where you step back and say, if I'm spending so much time putting out fires on a day-to-day basis, granted, we had to put out a lot of fires during COVID, but this is the time to now kind of reflect if we're still putting out same fires, more fires. This may be something that we want to consider as something to think about for our workflow optimization here. And then waste impacts the organization from, clinic times may be limited if there's a lot of waste maybe within your clinics. So maybe a full house. So thinking of if you are at capacity, there may be impacts to admissions and transfers and things that, your operational plans may be kind of constrained and limited. So waste certainly impacts lots of areas of our organization. And really the bottom line is that waste is bad for everyone. And our real goal is try to eliminate that. And it's really probably the biggest principles of lean, of a lean methodology. And really what we want to see is if we can, continue to engage our staff in the organization and really look to ways that we can eliminate some of that waste. So I want to walk you through some of the kind of 8 waste categories or areas. And so when you think when I start to go through this, I'm going to give a whole bunch of examples. And so maybe that will start you to think about, what do you do on a regular basis? Or is there a specific department that that kind of stands out? Like, yeah, I've heard that it's a train wreck. There may be a lot of waste of motion. And what that means is, we waste time moving from one point to another, whether that's searching for patients. And you can see these diagrams here. Again, when you get the slides, you might be able to zoom in a little bit better. But this is kind of a motion chart where you had a medical assistant searching for one patient and all the times that they moved around there, versus if it was reorganized and that MA had 3 patients, what that would look like. So there's also searching for medications and where those are stored and how do we access them? Are they readily available? Walking to equipment, how many times do we have to, whether it's a registration person that the armband scanner and the tag is on the other side of the room. So that person that's registering that patient has to get up every single time when they register a patient, walk to the printer, and then come back and attach, the printed out armband to that, as opposed to it being right on the desk, things like that. Or looking for different supplies or where those are located and if they're organized too. Again, the movement is part of that waste. So waste of defects. If you think about this, so here in the US, deaths from medical errors equal an airline crashing every day. That's a lot. And that, if you think about that, in the number of times that's happening, medical errors are happening, it's a huge number of people that are being affected by some type of defect. So we really must do better in this area. And so what do we think of, what's happening? A mistake becomes a defect when its uncorrected error reaches the customer or the patient in this instance. And so there's medication errors, wrong patient information, wrong procedure performed, or critical information, duplicate medical records. This one's a big one because how many times have you, maybe you have a legacy EHR system, you have your new EHR system, and you have a paper chart still. And how, you are documenting in the paper chart in the new one, or you have duplicate medical records because you don't have a system to merge them and create one. This happens a lot. So, this could lead to some type of defect, and it also leads, it's a waste. And so really, we really need to kind of have good processes to be able to detect, and really minimize any of the defects that occur in our organizations. So waste of transport. So this is when patients are moved multiple times in the organization. So whether they have to go into, say they have to go from their inpatient bed to surgery, and they do it too early. And so that creates a lot of waste time, wait times, for instance, if that transport happens prematurely. What about transport of specimens or equipment? Do we have, a process of where the mobile X-ray unit is it always located in the ED, or does it come from radiology to the emergency department every single time it's being used? Or do we have one centrally located in the emergency department? This is an opportunity around you're looking at your facility layout, and whether or not there are long distances to transport, say, from the emergency department to the lab. Not every rural hospital has a tube system, although that would be a luxury, certainly. We have to physically walk lab specimens to the lab from the ED. And so if that is a 5-minute walk versus a 2-minute walk, that could be a waste of transport. Waste of unused human potential. And so this is, are we using our people to do non-value added work, which is something that's kind of routine. When you think about, are we using our folks to the top of their license? A lot of hospitals are now leveraging LPNs on the floor. And are we, when we look at utilizing LPNs, are we utilizing them to the top of their license? And then at the same time, are we looking at our RNs and making sure that there's no duplication or overlap of some of that work? And then we elevate that RN to make sure that they are working at the top of their license as well. So it's really, but if we have folks that are, for instance, we experience this a lot, is that you have a psych hold in the emergency department or on the floor, and you need to have a sitter. And sometimes it's a nurse, it's an RN doing the sitting for the psych hold. Now, that seems to be kind of a waste of unused human potential. We're not utilizing that RN to the top of their license. So, it may be something that we consider a sitter program where we train and educate other staff members, that are looking for some additional hours, have an interest in supporting some of this program. We enroll housekeeping or dietary community members to be part of our sitter program, where then we can leverage our RN to work at the top of their license. Waste in inventory. This is probably something that's, very familiar to you all. Something that we certainly have processes in place, hopefully, that we look to make sure that we don't have a lot of duplicate medications. We check our supply dates or our out-of-date supplies and medications. Again, waste of that inventory is anything that might be excessive, more than what we need, and things that maybe are old and outdated that that are not used as well. So certainly having good systems in place where we are checking expiration dates, we are only ordering and utilizing what we need. So we looking at that from a inventory perspective. And waste of overproduction, something that whether it's making too much of something or making it too early. Was in a clinic not too long ago where they were printing out their patient intake forms on every single one of their patients. And they had they probably had 10 pieces of paper that they printed out for every single patient for their providers to review and look at. But they had all of that was the same paper and information that was located in their EHR. They just didn't use their EHR. For some reason, it was more of like a security blanket, they had those pieces of paper. And then they would, after the visit, they document it in the EHR and just throw all that paper away. They didn't even write notes on the paper. And so, you know, they just wanted to have it to make sure that they reviewed and, you know, got, you know, the medications, things that they could easily leverage their EHR to do. So, you know, lots of, you know, overproduction, we always think of like the paper, scanning, emailing, printing, that sort of thing. But there's also, you know, testing ahead of time could be a part of an overproduction or a waste of overproduction. Extra meals for patients who have been discharged. So not having a good process, that is a waste of overproduction. Now we have a meal prepared, a ticket on a tray for a patient that is leaving at noon today and will not have their dinner. So, you know, kind of think about maybe things that may be an overproduction for you all. And then waste of waiting. Certainly this is one that tends to focus on kind of lean methodologies. Is we look at the wait times. We hear that wait times has impacted our patient satisfaction because we have long waits in the clinic, or we have long waits in the emergency department. And this one tends to be the one that folks kind of focus on. And so there can be, and when you kind of look at what's contributing to the wait time, for instance, in the emergency department, well, we know that the emergency department there's a whole lot of, you know, waiting that goes on. And in this box here, you wait to get triage, and then you wait to be seen, and then you wait for your labs and your bed and your transport, handoff, and consults. You know, there's a lot of waiting that happens in the ED, but, you know, when we look at the process, you know, there may be just a small part of that process that's the largest wait time, which ends up being the biggest opportunity for improvement. We'll go into that in a minute, but again, the waste of waiting tends to be a big one in healthcare. And then this one, here's the last one of the 8 wastes. And this one is really around overprocessing. So duplication, repetitiveness, whether that is, you know, excessive paperwork. And, you know, we're trying to reduce the amount of paperwork of our staff and our providers. But one thing that we're working with an organization on recently was the documentation of the nurses, that they felt that there were opportunities for improvement, but they just didn't know where. And so focusing on what they were doing and documenting on every single shift to see if there was that duplication, or they were not documenting in the most efficient area of the medical record. You know, again, over processing tends to be a big waste here in healthcare. And so when you think about all those different wastes, maybe there's a department that kind of trickles to the top, and maybe that might, because of the amount of waste that is happening in that particular department or service line or area of the hospital. Doesn't have to be a clinical department, could be a non-clinical department. We look at that as different triggers. So when we think about what we're going to do to look at our workflows, we need to kind of have a focused area. And so when we think about that area, we think about, okay, what are some of those triggers? Maybe it's the amount of waste that we kind of perceive that's happening there. But what are some other ones? Maybe there's a department that has a lot of patient complaints, or the staff morale is low, you know, that we think we got to do something. We have to do something in this department or this area to support the staff. And because the morale is so high, in addition to maybe increased turnover, staff call outs, maybe it's an area that we've limited services to, or had some near misses. All of these triggers kind of come together, and we're able to maybe identify a few different departments that kind of hit the mark on these triggers here. And so with that, once we have that identified focus department, service, whatever it may be, we can really start to kind of hone in on our process improvement. And so that brings us to kind of once we've identified that area, what are we going to do about it? And so we have kind of developed kind of this four-part process, which can help identify problems, and what is the opportunity identification. How do we, start to work through and create a solution? And what are we going to do about it? How is it going to be implemented, sustained, and changed? And so it starts really with this team development. And so, okay, so say we're going to look at the inpatient unit. That's going to be our focus department, because we've had a lot of staffing turnover. We have really low morale. We had a near miss, or complaints are at all-time high. Okay, we're going to look at the inpatient unit. Well, we need to have a team that's going to be our process improvement team, and we're going to look at our workflows. And with that, we're going to develop a team. We're going to use the 3-3-3 method. I don't know if anyone's heard of that, but it's when we take the folks that are going to make up that process improvement team. It's going to be 1/3 of frontline staff. That may be the floor nurse, or some of the other, maybe a nursing manager. That's gonna be part of that team. Then we're gonna have 1/3 of key stakeholders. These are folks that interact with that inpatient unit. Maybe it's going to be a lab tech or registration staff, charge nurse, ED registration staff, somebody that these are considered your key stakeholders. The next third is going to be other members that have no working knowledge or direct interaction with that inpatient unit. These are what we call fresh eyes. These are folks that, no interaction. So it might be the clinic manager, for instance. These will be there, so we consider those fresh eyes. Then you want to have a sponsor. So somebody that's a leader that can kind of authorize organizational change, whether that is your administrator or the CNO or a physician potentially. And then lastly, a facilitator. So somebody that's going to keep the team on track. And oftentimes that could be somebody in HR. It could be maybe an educator if you have somebody, quality director, may make sense, but somebody that's going to really continue to push this team and kind of get the job done. So you always, ask, well, how many members should I have on this team? Well, certainly you need to consider the 3-3-3 method. So making sure that you hit all those key members of the team. So your frontline staff, your key stakeholders, a facilitator, and so forth. And then really it's the department as well, or the kind of the service area, clinical, non-clinical, whatever that may be. And kind of, so maybe it's 6 to 8. That seems to be a pretty good number for a lot of our clients, is around the 6 to 8 number. And then in addition to your team development, we want to make sure that we establish our rules of engagement. Set those right at the beginning. So you have your team of 6 to 8 individuals, and this is going to be your process improvement team for improving the workflows within the inpatient unit. We haven't gotten to where specifically, but this is going to be your team. And some of those rules of engagement, really setting the stage and the expectations right at the beginning. There's no rank, leave your title at the door. Things like no cell phones and sidebar conversations, no such thing as a bad idea. So this is create a space where you welcome, all different ideas, because, you can't operate in a vacuum, because you won't be able to, typically you don't have success in finding the solution, or working your way or noodling your way to that solution. So, laying out these expectations will really help create, a foundation and hopefully success in getting to some of those solutions related to kind of workforce or workflow optimization. The next phase is discovery, or the next step is around discovery. And when we mean by discovery, it's really kind of setting the stage. What is it specifically that we want to focus on? What is our goal? What is the purpose? Where do we want to be? What's our start and what's our end? And why now? Why do we need to, improve the workflow of the inpatient unit? And what are we trying to accomplish? So what is our goal? What's that end goal for our organization, or that end state, or what does success look like for us? And one way, when we think about what your burning platform should be, and what a burning platform is, it's really looking at a specific process to focus on. What we want to do, and I'll share a kind of a form that helps to outline some of this, is you want starting points, you want ending points of your process. And that will help really kind of align your team on your goals. What are we trying to achieve? What are the benefits? So outlining what are the benefits creates kind of buy-in. And that's certainly what we need to really make things successful, is we need to kind of bring everyone along and understanding what kind of the benefits are and what our team hopes to accomplish by approving some of our processes. And then certainly, why is this urgent? Why should we be focusing on this today? Why is it that we're getting this team together, that this is important for our organization? And why are we starting this today? So start to answer some of those questions, because that will fulfill what our burning platform is. We'll have a better understanding about why this is important, why we need to do this, and what do we hope to achieve. And so this just is an example. It's a good kind of worksheet to start to outline that, where we aim to improve, whatever that process may be, in whatever department that may be. And here's where the process begins and the process ends. What's our start? What's our end? And then what are our benefits and what are the reasons why? So having a great outline really can, again, kind of set the foundation and should be part of your discovery. In addition to kind of setting the stage and really focusing on the specific process that we want to focus on, we also want to retrieve kind of baseline data. So we need a kind of a starting point from a quantitative perspective around data, and that's department specific. So maybe that may include utilization data, department scheduling, staffing matrix, turnaround or throughput times, depending on the department, and any benchmark goals that we have, because all of this information can really support kind of the development of the gap analysis and understand what is current and future state, which we're going to use for our process improvement mapping, in addition to the rapid improvement events. Also, we want to do some interviews and observations. So this is the qualitative side of our discovery. Get a better understanding about current processes. What are some of the roles and responsibilities? What are some of the perceived strengths, gaps, and barriers? And what do folks think, if you interview other frontline staff members or managers or even patients? What might be some of the gaps or barriers that they may think? And then what we want to do is also directly observe. We want to understand the current activities. What's the communication process? is there things that we're observing that's impacting workflows that might be something that, folks that are doing it on a day-to-day basis are just not seeing. And so having that observation is really key in that discovery phase. And then our third step here in this improvement process is really around the opportunity identification. And we do this by value stream mapping. So if you are familiar with Lean, you may be familiar with value stream mapping, and it's really a kind of an opportunity to look at what the current processes are and identify any inefficiencies. So what are, going back to the non-value added activities, where may some of those be located within a whole process? And it's really, when we map this out, and it's really called mapping because we're actually kind of laying it all out. Is there, things that we ask ourselves when we look at it? I do that step again and again. And why does she do it that way? This many people were involved in this, and why do we do this? And then I didn't realize we did it this way. This is some of the things that we hear when we do map out a process. And when we utilize that team, maybe it's those fresh eyes, people that are not involved in that day-to-day process that ask these questions. Why do we do that step? It's a good question. And so this here is, again, looking at that map and mapping out that process. You can really identify kind of where that non-value added activity is, or if there's kind of variabilities in practices, there may be silos that exist, or areas of sub-optimization. So once we kind of can focus, so you can see here in this example here, you can see where the bottleneck is relative to this process. And this is where we may focus our rapid improvement event on, is where there may be a bottleneck or identify an area that is suboptimal, for instance. And so this is just an example of an OR process map or value stream map. And so the different steps in which the process includes, and maybe in one of those areas, if we did time studies, for instance, we might be able to see where there may be some areas for improvement. So what then, once we have kind of identified our area for improvement, we want to make sure that we, implement an action plan. What are we going to do to change or improve on that that process? And so what changes can we make that will result in an improvement? And then utilizing kind of a priority matrix. So we want to determine the rapid improvement events. So those events that are going to close those gaps, or they're going to go or expected impacts based on the value stream. So for each of those rapid improvement events, there are going to be steps that are going to happen determined by each of your team members. So we may look at them as short-term changes, or which are kind of your immediate, or there may be some more complicated action steps, might be medium-term and long-term. And so those are kind of the action steps that will qualify for maybe like an action plan or an implementation plan, where there needs to be kind of owners assigned and timelines for completion. Those short-term process improvement, those are the just do it's. Those are, well, we just need to move the armband printer to the desk. That is a short-term process improvement. Those are the just do it's. The other ones that might be facility improvement, that's going to be a longer term kind of action step, maybe more complicated, maybe needing various owners and a timeline for completion. these are some of the things that we want to kind of hone in on. Your action plan, your improvement implementation. So again, determining how we will know that a change is an improvement. So how are we going to measure it? Are we utilizing SMART goals to kind of measure success in any of our implementation? How are we monitoring this? Are we, this is something that needs to be monitored to sustain any improvements. So is there a meeting cadence that we can establish so that we are monitoring and kind of documenting any improvements or what might be some barriers to improvements once we've identified where that maybe that area is for workflow improvements. Then having a, kind of a team aspect on monitoring and kind of documenting that improvement timeline or your action plan that you've kind of laid out. And we want to do it on a daily, weekly, monthly, yearly basis. So you think, oh my gosh, that's a lot. But, how many times have you done something or changed something or implemented something new and just kind of forgot about it or did not follow up or did not monitor it? And then you come to find out in 6 to 10 weeks, hasn't been implemented, nothing has changed. So having that discipline around continuous monitoring and documenting will really help kind of lead and lend itself to some improvement there. And so when you're thinking about this, so how are we, how are taking all that process improvement, how can we apply that to some of our workflows? So, certainly here are some examples that we've encountered, and that may be something that you all can kind of start to think about. It's very organizational, department specific. Not every workflow process it could be suboptimal. Certainly there are lots of opportunities for improvement, and just kind of honing in on what makes the most sense for our organization, and get some small wins. Certainly having some smaller successes will really kind of start to build the team if we've never kind of embarked on the process improvement journey. And so what are some of those applications specifically to workflow? Standardization of your supply room. And so making sure that we have any of those just-in-time supplies, that we decrease that waste around expired medications or supplies. If we looking at redundancies within the documentation process, what I had mentioned, that example about the nursing documentation and the duplication that exist, and or not fully leveraging a EHR, or having different workflows and processes on documentation. Because how many times have you been trained by one nurse that's done it one way, but it's really not, and then that gets passed on, but it may not be the most efficient way to document. And so it's just that continuous cycle of suboptimal documentation until somebody identifies it and says, no, this is what we should be doing. And maybe that's a good process improvement or a rapid event where we figure out what the most optimal way that we document, what's the most efficient. You can even measure that. It takes X amount of time to do it this way versus this way, and this is the way we want to do it. And so again, getting, and studies have shown that, if you reduce the amount of documentations or redundancies in documentation, it will lead to a greater time for nurses to be at the bedside. Because, you've experienced it before. Our documentation and our time in front of a computer has really pulled nurses and frontline, patient care staff away from the patient bed. And that's not why they got into kind of nursing or patient care. So looking at ways that we centralize functions to really kind of increase efficiency. Many organizations have kind of centralized a appointment scheduling or a scheduling function. So we don't have it located in multiple clinics, we have it centralized. Sometimes that works, sometimes it doesn't, but that could lead to efficiencies. In addition to, you don't need a scheduler in every single one of your clinics. We may only need 2 as opposed to 5. And so how do we kind of centralize that function if we have that reduced amount of staff? Certainly physical movement, a lot of time wasted in the movement area. We talked a little bit about that. Kind of dysfunctional silos that may encourage batching or delays. So silos being, maybe it's you have silos that exist between the ED and the inpatient. And so there may be kind of delays that happen getting folks to the floor from the ED because in a silo exists, or there's, that strife between the 2 units. And that can certainly cause significant delays potentially and, poor dissatisfaction in our patients. Our start times, again, you likely have encountered a lot of these, but now it's thinking about utilizing process improvement to improve our workflows and to help really support kind of our workforce. Is there ways that we can eliminate the waste, get time, because time is of the essence, back to our workforce so they can be doing the value added activities. And so that's what I leave you with. There's certainly a little bit of time for questions. If I don't have all the time today, certainly email me. I don't know if we have any questions in the chat, but hopefully that kind of started to get your brain thinking about maybe there are some ways that we can look at supporting our workforce through workflow optimization.
Excellent. Thank you so much, Lindsay. So I'm checking the chat and I don't see anything yet, but we still have a couple of minutes. So if anyone has a question they would like to put in the chat, actually, I think one just came through. Question, what is a priority matrix?
That's a great question. So a priority matrix is when, say you have an action item. So I'm just going to say, increase your swing bed utilization, for instance. And for a priority is maybe a 4-part grid. What are maybe the resources that are going to be required to get this done? What is the time? And what is the impact to the organization? Is it high impact where we're going to get, increased volume, we're going to get increased financial benefit from that? Or is it kind of a lower impact where it's not going to be, financially viable for our organization versus the amount of resources? Maybe it takes a lot of resources, but it's going to be high impact. So it's going to be up in that kind of the top quadrant. So again, resources and impact and where those kind of fall for your different action items. And you start to kind of categorize that. And so maybe you want to just focus on the highest impact and maybe the middle of the road resources. That helps to kind of look at where you prioritize your action plans. Hope that helps. And I can, I'll include just a snapshot or a grid that will help explain the priority matrix. And I'll include that as an attachment.
Great, that would be excellent. Thank you, Lindsay. Okay,
yep.
I don't see anything else in the chat. And since we have less than a minute, I will go ahead and wrap up. But if you have a question or you think of a question later, please don't hesitate to reach out to one of us and we will make sure that your question gets answered. And go ahead and be looking for that email that's coming to you later this afternoon or possibly early in the morning with a link to the recorded webinar as well as a copy of the slides and the resource that Lindsay offered. And I guess, let me double check one last time. I see nothing. Okay, thank you so much, Lindsay. That was a really excellent presentation. Lots of great information. We appreciate it. And thanks to everyone that joined us today. We will see you next time.
Thanks all.